Let us briefly review what we have covered. In Module 1, we learned about classical conditioning, how behaviors are learned through association. We explored systematic desensitization, flooding, and aversion therapy. Module 2 covered operant conditioning, that is, how consequences shape behavior. We discussed reinforcement, punishment, and token economies. Module 3 introduced social learning theory, how we learn through observation. We covered modeling techniques and social skills training. Now, here's the critical point. Real-world cases rarely fit neatly into one category. Comprehensive, effective treatment integrates all three approaches. A person with social anxiety did not develop it through just one mechanism. Multiple learning processes are involved, so treatment must address all of them. Today, we will learn how to do that integration skillfully. Case formulation and selection. Behavioral case formulation is systematic. We start by identifying target behaviors. They must be specific, measurable, and observable. Feel better is too vague. Attend 2 social events per week without leaving early is specific. Next, we conduct a functional assessment using A-B-C analysis. What are the antecedents? What triggers this behavior? What exactly is the behavior? What are the consequences? What does the person gain or avoid? We identify maintaining factors. What's reinforcing this behavior? What avoidance patterns keep it going? We assess the learning history. How did this develop? We evaluate the environmental context, like what triggers exist, what resources are available. Critically, we also identify strengths and assets. What protective factors does this person have? What's working well? Building on strengths is as important as addressing problems. Only after this comprehensive assessment do we develop the intervention plan, and that plan must match the function of the behavior. Choosing the right intervention requires clinical judgment based on the formulation. If the problem is primarily fear or anxiety based on learned association, we use exposure-based approaches rooted in classical conditioning principles. If there is a skill deficit, the person never learned how to do something, then we use modeling and social skills training from social learning theory. If a desired behavior occurs too infrequently, we use positive reinforcement strategies from operant conditioning. If a problem behavior occurs too frequent, we use differential reinforcement or extinction. If a maladaptive pattern is being maintained by its consequences, we use contingency management to rearrange those consequences. And when the presentation is complex, which is usually we combine approaches in a coherent treatment plan. Let me describe 2 powerful evidence-based applications. Behavioral activation for depression is as effective as antidepressant medication for mild to moderate depression. That's a remarkable statement backed by multiple large studies. The theoretical foundation is simple. Depression involves a lack of positive reinforcement. When people become depressed, they withdraw from activities, which means they receive even less positive reinforcement, which deepens the depression, a vicious cycle. Behavioral activation reverses this. We start with activity monitoring to establish a baseline. Then we conduct a value assessment. What matters to this person? What brought them joy before depression? And all. Next, we schedule activities aligned with those values, starting small and gradually increasing. We problem solve barriers proactively and we reinforce completion of scheduled activities. The counterintuitive insight is that action precedes motivation. We don't wait for motivation to return. We schedule activities first, and motivation and improved mood follow the behavior change. Exposure and response prevention for obsessive compulsive disorder is another gold standard treatment with 60 to 80% symptom reduction rates. The components are straightforward but challenging. Exposure means deliberately confronting feared situations or thoughts. Response prevention means resisting the compulsive behaviors that normally follow. For someone with contamination fears, exposure might be touching a doorknob they believe is contaminated. Response prevention means not washing their hands for at least 2 hours afterward. What happens? Anxiety peaks. It's very uncomfortable. But then, crucially, it naturally decreases through a process called habituation. They learn experientially that the feared consequences do not occur and they can tolerate the anxiety. This combines classical conditioning, extinction of fear response with operant conditioning by breaking the negative reinforcement cycle where compulsions reduce anxiety. Habit reversal training, developed by Azrin and Nunn in 1973, treats repetitive behaviors like tics, hair pulling, nail biting, and skin picking. It has 4 components. Awareness training teaches the person to recognize the urge before the behavior occurs and to notice when they are engaging in the behavior, as it's often automatic. Competing response training involves performing an incompatible behavior when the urge arises. For nail biting, you make a fist. Can't bite your nails if your hand is in a fist. Motivation enhancement involves reviewing the negative consequences of the behavior and benefits of stopping. Social support means involving others to prompt the competing response. It's elegantly simple and remarkably effective for these specific problems. Parent management training is the evidence based approach for child behavior problems. Rather than treating the child directly, we teach parents behavioral principles and make them the primary change agents. Parents learn to give positive attention and specific praise, deliver clear commands, and set expectations, provide consistent consequences. They implement timeout procedures correctly, use planned ignoring for attention seeking behaviors, and set up token economy systems at home. This is powerful because parents are present for all the child's problem behaviors and the skills generalize automatically to the home environment. Children's behavior problems often stem from inconsistent parenting or unintentional reinforcement of problem behaviors. For substance use disorders, contingency management directly addresses the core problem. Drugs provide powerful immediate reinforcement while the benefits of abstinence are delayed and uncertain. Voucher-based reinforcement therapy provides immediate reinforcement for abstinence. Clients provide urine drug tests 2 to 3 times weekly. Each negative screen earns vouchers that can be exchanged for goods and services. The voucher values escalate with consecutive negative screens, creating momentum. But a positive screen resets the value to the beginning. This creates immediate, tangible consequences for abstinence, competing with the immediate reinforcement from drug use. Research shows significant increase in abstinence rates. Applied behavior analysis for autism spectrum disorder involves intensive early intervention, often 20 to 40 hours per week for young children. The techniques include discrete trial training, highly structured learning trails with clear antecedents, promoted responses, and immediate reinforcement. Natural environment teaching embeds learning in everyday contexts. Functional communication training teaches alternative communication methods. Social skills training addresses the interaction deficits. Prompting and fading gradually reduces support as skills develop. The evidence of applied behavior analysis is strong. There are significant improvements in IQ, language, and adaptive skills, especially when started early and delivered intensively. It is comprehensive application of all the behavior principles we have discussed. Behavioral sleep medicine treats insomnia behaviorally. Stimulus control therapy is based on classical conditioning principle. The goal is to break the association between bed and wakefulness and create a strong association between bed and sleep. The rules are strict. Use your bed only for sleep, and there should be no reading, watching TV, or worrying in bed. Only go to bed when you are actually sleepy. If you are not asleep within 20 minutes, leave the bedroom and do something relaxing elsewhere. Return only when sleepy. Wake at the same time daily regardless of how much sleep you got. No daytime napping. It feels counterintuitive, leaving bed when you can't sleep. But the success rate for chronic insomnia is 70 to 80%. It works by strengthening the bed-sleep association. Biofeedback makes invisible physiological processes visible, allowing you to learn to control them. Biofeedback measures muscle tension and treats tension headaches and TMJ. That is, thermal biofeedback tracks hand temperature for Raynaud's and migraines. Electroencephalogram biofeedback monitors brain waves and can help with attention deficit hyperactive disorders and anxiety. Heart rate variability biofeedback regulates the autonomic nervous system for stress and post-traumatic stress disorder. A sensor provides visual or auditory feedback about your physiological state. You learn through trial and error, that is operant conditioning, to control that state. It also pairs relaxation with the physiological changes like classical conditioning. The combination is powerful for disorders with a strong physiological component. Behavioral couples therapy is based on social exchange theory. Relationship satisfaction depends on the ratio of positive to negative interactions. The interventions are practical. Behavioral exchange increases positive interactions through deliberate caring gestures and shared pleasant activities. Communication skills training teaches active listening, I statements, and validation. Problem solving training provides a structured approach, define the problem, brainstorm solution, evaluate options, implement chosen solution, review outcome. Contingency contracting creates explicit agreements. I will do X if you do Y. The focus is on changing behavior patterns and not the feelings. The assumption is that feelings follow behavior change. Evidence shows improved relationship satisfaction in about 70% of couples. The third wave behavioral therapies integrate traditional behavior change with acceptance and mindfulness. Dialectical behavior therapy, developed for borderline personality disorder, teaches mindfulness, distress tolerance, emotional regulation, and interpersonal effectiveness. It accepts the change is hard and balances acceptance with change strategies. Acceptance and commitment therapy promotes psychological flexibility. Rather than trying to control or eliminate uncomfortable thoughts and feelings, you accept them while committing to values-based action. You change your relationship with thoughts rather than the thoughts themselves. These approaches represent an evolution, not a rejection of traditional behavior therapy. They integrate acceptance with behavior change. Now, ethics. Behavior therapy raises important ethical considerations because we are systematically manipulating consequences to change the behavior. Several principles guide ethical practice. Informed consent means clients clearly understand the procedures, including any discomfort involved in exposure therapy. Right to effective treatment means we use evidence-based approaches, not unproven techniques. Least restrictive alternative means choosing the least aversive intervention that's likely to be effective. Dignity and respect means never using dehumanizing procedures. Data-based decision-making means monitoring progress objectively and changing course if something isn't working. Cultural sensitivity means adapting techniques to cultural context. Transparency means the client understands the contingencies, we are not manipulating them secretly. Cultural competence is not optional. Culture shapes how behavior is expressed, what's considered problematic, what interventions are acceptable, and what outcomes are valued. In assessment, cultural factors shape symptom presentation. In intervention, we must adapt techniques to cultural values. Family involvement expectations differ dramatically between collectivist and individualist cultures. Communication norms, verbal and non-verbal, vary by culture. Reinforcers must be culturally appropriate. What's rewarding in one culture may be neutral or even punishing in another. Skills must fit the cultural context where they'll be used. For example, in some cultures, individual assertiveness conflicts with values of family harmony and respect for authority. Measuring treatment outcomes rigorously is essential. We use multiple methods: frequency counts, how often does the behavior occur, duration, that is how long does it last, intensity, ratings on standardized scales, and latency, how long from prompt to behavior. We use validated standardized questionnaires, goal attainment scaling for individualized progress, and direct observation in natural environments when possible. Self-report alone is insufficient. Multiple baseline designs stagger intervention across different behaviors, settings, or people. If each behavior changes only when intervention is applied to it, we have demonstrated control. These designs allow rigorous evaluation even when large group studies are not feasible. To conclude, behavior therapy is practical, evidence-based, and focused on observable behavior. It uses scientific methods to understand and change the behavior. Classical, operant, and social learning principles explain much of how people learn and act. Good assessment helps us choose the right interventions, and using data helps us know if our work is truly effective. Culture, generalization, and maintenance must always be considered, and ethical practice means respecting clients' dignity and well-being. Behavior therapy has a strong evidence base and leads to real, meaningful change for many problems. These methods are based on basic learning principles which can be applied flexibly in many situations. I wish you all the very best as you continue learning and using behavior therapy. Thank you for your attention throughout this course, and I hope you can apply these skills to help improve people's lives.